Good morning, everyone. I'll just give it a couple more minutes to allow extra people to come on board.
Hello, everyone. It's nice to see people dialing in, and welcome to the event, virtual event, hopefully at the end I'll send you some slides afterwards and you can follow up with things then as need be too.
Good afternoon, everyone, and welcome to today's webinar, Arthritis, Osteoporosis and Falls. My name is Renata and I am an Injury Prevention Officer here at Injury Matters and the Stay on Your Feet program. We are pleased to be hosting today's webinar with Professor Anne-Marie Hill, who will present insights from the latest evidence and practical strategies for management of arthritis, osteoporosis and falls. If you didn't register for the webinar but joined through a forwarded link, you won't be able to access its features such as the chat and Q&A functions, but you can still quickly register for the webinar through the website and access your own link. Before we begin, please let me acknowledge the Whadjuk Noongar people, who are the traditional custodians of the land on which Injury Matters work, and recognise Aboriginal and Torres Strait Islander peoples' continuing connection to land, waters and community across Western Australia and across Australia as well. We pay our respects to elders past, present and emerging, and welcome any Aboriginal and Torres Strait Islander people joining us today. A few housekeeping points to note before we start. Please, to allow the presenter to be heard clearly, can you check that your microphones are muted? We have scheduled a time for questions and encourage you to send them through as you go. If you have more than one person in the room with you today, we'd appreciate if you could send us a quick chat by the tab and let us know how many people are listening with you. If you face any technical issues during the presentation, please write them in the chat box and we will do our best to help you. I do have Suzanne helping me with the tech side today. And lastly, this webinar will be recorded and links and notes will be provided and sent via the email that you registered with. So at Injury Matters, we work with people and organisations across WA to innovate and deliver injury prevention and recovery solutions. Solutions that keep people safer and healthier at home, at work and on the go, and that save lives and make our community stronger. Our approach is as expansive and inclusive as our remit, which spans everything from road safety to trauma recovery and falls to substance-related harm. As a not-for-profit organisation, we work with local communities, industry, government and our health, emergency and social service partners, drawing on the latest research, evidence and lived experience here in WA. Our three programs aim to raise awareness of injury risks, consequences and solutions, prevent injuries through a range of education and support programs, support the recovery of people, families and community impacted by injury and trauma, advise and enable local and national agencies and policymakers to make smarter, safer, more informed policy decisions to support the needs of the community we work alongside. Together we find and share injury prevention, recovery and policy solutions that keep everyone safer and healthier. Solutions that reduce the far-reaching physical, emotional and financial impact caused by injuries and trauma. So a quick overview of today, we'll look at the Stay on Your Feet program and the impact of falls, and then I'll introduce our guest presenter, Professor Anne-Marie Hill, before finishing up with a question and answer section. Today's training is brought to you through our Stay on Your Feet program with the support of the Department of Health WA. The Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults on how to prevent falls in the community. Stay on Your Feet has 3 key messages that we use throughout our campaigns and community and workforce engagement. These 3 messages are move your body, improve your health and remove hazards. And this is where we get the overarching slogan, move, improve, remove. Falls are defined as an event which results in a person coming to rest inadvertently on the ground or floor or a lower level, with about 1 in 3 people over 65 expected to fall each year. In Australia, falls are the leading cause of injury, hospitalisation and death, with 43% being injury hospitalisation and 42% of injury deaths caused by falls. The 2024 WA Falls Report was released earlier this year and highlights that during 2021 in WA, someone died every 17 hours due to a falls injury. In 2020, it was 19 hours, so we've seen a change there. And in the 5-year period from 2018 to 2022, there was a 31% increase in the number of falls hospitalisations among people aged 65 plus. These result in a real impact on an individual's life that can lead to a loss of independence and confidence, increased concerns of falling, and difficulty doing daily tasks. Further complications can result when you factor in conditions such as arthritis and osteoporosis. Today's webinar will explore the latest research evidence for falls in people living with arthritis and osteoporosis, and practical strategies and interventions to manage and reduce the risk of falls. Professor Anne-Marie Hill is Senior Principal Research Fellow in the School of Allied Health and the WA Centre for the Health and Ageing. Supported by the Royal Perth Hospital Resource Foundation, her research seeks to improve older people's health and well-being. Professor Anne-Marie Hill is a Fellow of the Australian College of Physiotherapists and has over 30 years clinical experience working with older people, including conducting large clinical trials with a strong focus on hospital falls prevention, residential care, older adults, education, and working collaboratively with older people to reduce falls. Professor Hill also collaborates with Aboriginal and Torres Strait Islander researchers and communities, focusing on sustainable physical activity programs for older Aboriginal people in WA. Please welcome Professor Anne-Marie Hill.
Thank you very kindly, Renata, and I'll just start sharing my screen. And perhaps you can confirm, can you see that okay, Renata?
Yes, that's fine. It's looking good.
Okay, terrific. All right, thanks everyone. It's disconcerting, isn't it, if I start talking and you can't see what I'm saying. It's lovely to be here today and wonderful to talk to you. Thank you for making the time to listen. I do note that when giving this sort of talk, it tends to be an overview, and it's hard to give information sometimes that's specific for all of your different settings. So I hope to provide some summary information and some further resources, and some of these you may well have access to already, because I'm sure many of you are very experienced in your own areas. So it will be a case, as always, of you'll hear some things and probably have a bit of your own homework to do afterwards as part of your CPD. So that's terrific. I'd first like to also acknowledge the Whadjuk people of the Noongar Nation as traditional custodians of the land in Boorloo. I pay my respect to elders past and present of all nations, And I'd like to particularly welcome and thank any Aboriginal people for their attendance today and those who may listen to the presentation. And as part of my reconciliation journey, I have been very fortunate to work with a wonderful group of elders and Aboriginal communities. And I'd like to particularly thank and acknowledge Dr. Margaret Gidjup, Wajak Noongar elder, who has been such a source of wisdom for me, and also particularly thank Margaret for the beautiful artwork that she's loaned me to do my acknowledgement to country. As you know, whenever doing presentations, if you're speaking to someone like me who works in a team, there's a lot of team and funding and support behind it. And I'd like to just particularly thank the Royal Perth Hospital Research Foundation, who have funded my research for the past 2 years and are continuing to fund it for the next 3 years. So thanks to the foundation, it's really amazingly appreciated by our team, their support. And of course, also like to thank NHMRC, who've been funding my investigator grants, and the WA government for the research support they've given me as well. It is sobering, and Renata brought this up, just to think that in the time that we're going to listen to this webinar, there will be 3 or 4 people admitted into our ED with a fall. So this is something that is, I think, allied health, we need to start really looking at the resources we're devoting to this. I would be hoping, for example, just to try to think of some examples, that everyone who's listening to this presentation today would take this presentation and would essentially go and do a short presentation at their own setting to train more people about falls prevention. And that for every time you give a presentation, you'd also maybe have a consumer presentation. And I do think that in hospitals and residential care, we need to start looking at saying, well, who's our falls specialist? What are we doing about falls? And blending that into care for older people. So good care for older people will, of essence, include good falls prevention, which is what we want. And today, particularly, we're focusing on a really vulnerable group of people in some respects in our population, because we know that over 1 million people in Australia have osteoporosis. So when people fall and they have osteoporosis, then fractures are going to be the result, and sometimes very low trauma falls. So it's important that we bring our best expertise to bear on this. Everything I'm going to say today, you can find good summaries of in the latest guidelines. And these are very useful. I was just checking through the latest version, and it really is excellent and contains good summaries. So I would strongly suggest, if you're in a group setting, a group community practice, or if you're in a aged care, that you download these and keep them in a prominent place on your desktops and try to spread that news around to others, because it's really good information. And the same with what I'm going to talk about with arthritis as well as osteoporosis. You can find excellent resources for consumer and health professional use. I would like to draw your attention immediately to the consumer education that you would want to provide. And so if you go to the Arthritis Foundation, there really are some excellent resources for consumers to use. And of course, we're hosted by WA's premier falls prevention site, Stay on Your Feet. And so I really would urge you all as health professionals that you would routinely use consumer resources as part of your treatment. So you would specifically say to anybody that you're going to give falls prevention exercises to, or treatment to, or assess their risk of falls, that you give them a hard copy handout of something, or you show them a video, or you direct them to where they can find information online. And that you don't actually just give them a link and say, by the way, you can find information there. You take a few minutes to open the link and you show them some of the information and talk about how they can personalize it to themselves and give them information. And always remember too that sometimes people feel a little hesitant to talk about symptoms of their illness, and we know that people are hesitant to talk about falls. So you can give that in a way of saying, here are some things for you to follow up with afterwards. I thought these particular things might be interesting to you, and also encouraging that person to not suggesting that you're seeing them as a person who doesn't have good agency in their own life, but you're saying to them, by the way, you may find this brochure I'm giving you, feel free to pass it on to other people of your family and friends if they haven't had some of this information before. So you're giving the person a sense of leadership and ownership. You're not just giving them those resources and suggesting they're the only person that need them. You're saying, oh, look, I as a health professional am trying to spread this information around. So please, I do urge you, use resources for consumers with your treatment, because that's going to help the older person, and we'll talk more about that as we go along. So when you want to think about your overarching strategy, I find this a really helpful way to think of it myself, and I'm hoping that some aspects of it might really touch base with yourself. It's firstly really important that we think that all older people, so for the purpose of our talk, we use the category of 65 and over, but of course people over 55 with chronic health conditions may well fit into the type of categories that we're thinking. So everybody needs to be active who's older. That's very, very important. It's active lives are going to lead to healthy older aging. Active lives are going to lead to independence. Active lives are going to help you keep cognitively sharp and physically sharp. So if we have our person in the red who has arthritis and our person in the blue there who has osteoporosis, this advice applies to them absolutely. We don't need to start whittling them out. And as we will find out, unfortunately, sometimes with people with osteoporosis or arthritis, they are screening themselves out and thinking, well, that advice to be active for all older people doesn't apply to me because I've got this limiting condition. But it's the opposite. So we need to always give the message, everybody needs to be active in exercise. Secondly, we then need to give the messages and encourage consumers to take on the message that preventing falls is up to all people and applies to all older people. Whether you are active, whether you are frail, whether you have arthritis, whether you have osteoporosis, falls prevention is a key part of your healthy aging strategies. And interestingly, it's the same message. The evidence tells us the same things. If we prevent falls, we will increase people's independence, assist them to maintain their independence. We will help them to remain cognitively sharp. We'll help them to keep physically active. We'll help them to be able to do more. So therefore, those messages apply to all older people with or without arthritis or osteoporosis. So what about our person in the red who has some arthritis? To manage their arthritis, we will add. We will add and modify. We will not take anything away. We will do active falls prevention, active participation in exercise, and we will modify and add some specific things that we might need to for the arthritis. What about our person in the blue who has osteoporosis? We will add and modify. So we will not remove any aspect of the exercises they need to do to keep active, and we will not reduce or remove any of the activities that would prevent falls. When I'm an older person, to be active, I need to turn a light on at night because my vision is a little reduced at night compared to much younger people. If I want to prevent falls, I will turn that light on at night. If I'm going to manage my arthritis, I might need a touch lamp, but I will still need to turn the light on at night, but I might need a touch lamp to do it. If I have osteoporosis, I will still need to turn that light on. I will just might need to have been taught some specific techniques about how to carefully get out of bed so I don't feel pain in my back when I do that. But I'll still be getting up actively at night to safely go to the toilet, turning my light on to allow for my falls tip. If I am frail or I have fractures from my osteoporosis, I may need to modify some of my activities in the short term, but I will then go on to adding. I will add the exercises I need to do to bring my activity levels right up. I will modify some of the exercises so that they're really specific for working to build my osteoporosis to its best management possible. So I'm hoping that that gives you an idea that when we are working with people, we're keeping those overarching strategies in place all the time. We will have some particular alerts that spring to our mind, and these aren't everything by any means, but just wanted to bring up a couple to you. If you're meeting people with arthritis or osteoporosis, you will have a few alerts that spring to your mind that you will bring into your screening, your history taking, your management. Firstly, if you're working with people with chronic diseases, you will suspect osteoporosis much more proactively and begin to work on it. So we know, of course, be familiar to many of you that if people have COPD, then they may have an increased risk of osteoporosis due to the medications and side effects of the COPD. We know that if people have had a diagnosis of cancer and they've received treatment, perhaps they have increased osteoporosis risk. These will be things that we watch out for. We start to proactively manage. We start to look out and make sure we're communicating with their medical team. Again, if we're suspecting osteoporosis and we're looking at older people, we will be alert to any low trauma fractures. Firstly, we will be alert to their presence. So if someone who is 70 and we know has some history of perhaps cancer medications, if they say they have pain in their foot, we may suspect and consider, could that be a low trauma fracture? And of course, if any of our patients who are coming for us for treatment for a sprained ankle and they have been diagnosed with a fracture, we will immediately start quizzing them about, how's that fracture occurred? Is it low trauma? In that case, we will, of course, immediately screen them in as high risk of probably having osteoporosis, preemptive diagnosis, head back to your doctor for that treatment. If we know people have arthritis, we will be on the alert for any uncontrolled pain and making sure we're managing that. And we'll be on the alert for any chronic diseases, such as repeated falls, frailty, arthritis and osteoporosis, of affecting people's mental health, of affecting their ability to participate and enjoy life. And so if someone's telling us they're not doing the exercises we'd like them to do, we'll be alert for asking them about their motivation and talking with them. We'll particularly be alert for medication adherence. And I've put in that quote for you there, which I think is interesting, which is on the Canada Osteoporosis website. And they've put, this is on the kind of front page where they've tried to put some information for consumers. And you can see there, they're trying to say to them, please take your medications because they work. And if you take them, you will be really reducing your risk, because we know that medication adherence with osteoporosis is fairly poor. And we know that people do not take their osteoporosis medication or they drop out of taking it. So we know that's a really important thing. We'll also be alert for people at high risk of falls. And that includes, we go right back to our previous slide, that includes every single older person. Any older person with or without osteoporosis who has a history of falls is at high risk of falls. So if one of our patients with osteoporosis tells us they've had some falls, we know that we need to prioritise excellent falls prevention management for that patient immediately and urgently, because we can't run the risk that they'll fall again and possibly fracture. If people tell us they have vision problems and we must assess this and screen carefully for vision problems, then we know that they are at very high risk of falls, almost double the risk. sometimes our patients can tell us they don't have vision problems, and it is important to quiz them a little more closely, because some patients will say, oh, well, I don't have a problem with vision. Okay, do you have prescribed glasses? If so, why are they not on you? So sometimes our patients can say, well, my vision's adequate for getting around, but actually it's not. They are losing some of their ability to judge distances, stairs, obstacles, more bumps, more things happening because they've got glaucoma or because they are not wearing their prescribed glasses. We know that if people tell us about dizziness and we need to ask them about dizziness, that's going to be an important symptom and make people at risk of falls. And of course, the big thing for us that comes across many chronic diseases is weakness. If people have musculoskeletal problems, if they have arthritis, if they have anything that is making them not do much exercise, then they are going to have lower limb strength decline. If they have been in hospital, they will have been losing muscle mass every single moment they are lying in bed. So we know that we are weakening older people for every day they are lying in a hospital bed. And we need to urgently consider how we can prioritize reconditioning and strengthening those people. So those are kind of some alerts that we're going to be watching. Okay, so when we want people with arthritis and osteoporosis to manage their falls prevention, the first thing we need to do is give them the standard advice that we're going to give all older patients, which is, okay, you need to be doing your general activity, your strength activity, and your balance work. These are all important for managing your osteoporosis and stopping yourself falling if you have osteoporosis. So that's our general guideline. These are the 3 things we want to tick off with older people, that we want them to be active in this way. Now, of course, the issue for us comes in thinking about how are we going to do that. And this is where, as allied health, we have a lot of advantages, because we can really tailor the type of activity we ask people to do according to their life circumstances and their chronic disease, making sure they enjoy it. And you can see the person in the first box, who's myself, doing some exercise there at the gym, is going to have different requirements to the person in the second box, who's a frailer lady who lives in a residential care setting and will need some assistance. But you can see there is still accomplishing some very good resistance training. So very important for us to be guiding our patients in really attacking that be active in a way that's going to be feasible and enjoyable and sustainable for them. All exercise must include balance. This is a key input for older people. If we look at the very well cited meta-analyses of Sherrington et al. And our own researcher in Australia here, Kathy Sherrington, very big exercise reviews, and we know that trials that successfully reduce falls include exercise that has moderate or high challenge to balance. It explains over 2/3 of the variability in trials. If you don't challenge people's balance, you won't reduce their falls risk. So this means that for people with arthritis, if they have a kyphosis, we know they will already have poor balance because of their kyphosis, but we've still got to figure out how to challenge that balance safely. So we need to put on our thinking hat and adapt our exercise, because no balance challenge is not going to be able to reduce that person's falls risk. So moving on to osteoporosis, I'm not going to go through this slide in detail, but you do need to think about, whenever you're seeing people with osteoporosis, that you think about the screening. So if they haven't been to have a FRAX from their doctor, or they haven't had a DEXA, you're suggesting that they speak to their doctor about that. You are reminding them about bone health maintenance. So you're making sure they think about the strength training and the balance challenge they do, and the weight bearing is going to be helpful for their bone health. You're thinking about recommendations for frail older clients, and you can see that they directly fall into falls prevention work. And you're remembering that for people in residential aged care, calcium and vitamin D should be standard care. And Whilst we as allied health are often not referring directly to specialists, we know that there are pharmacological solutions for osteoporosis and good pharmacological solutions for people with arthritis. So we want to encourage our clients to seek them out and to be dialoguing with their specialist about how they themselves can successfully take these helpful medications. Because we know that people end up with some side effects and then sometimes just stop the medications when they would have effect. So we're thinking about that kind of advice to give our clients. So what sort of exercise do we want to give our clients? It is really important that they are doing resistance training, that they are doing impact training, and that they're doing balance exercises. And we may need to adapt these for recent vertebral fracture. The guidelines do find on consensus that there's no evidence that treating people with resistance training causes fractures, and there is evidence that you can help people to develop better posture and you can help people to develop better weight bearing and better strength and movement by giving them strength training. So people may need some careful targeting in how they're going to do their extension exercises of their back, but you certainly should be giving them. We know that people need to do some impact training. So if they can't do it immediately, if they're not able to do running or jumping, then they can do some modified work. They can do some low step ups, they can do some foot stamping, they can do some modified squats so they can build their impact training. And again, you're going to see me keep saying this, they need to do their balance exercises. I love this slide, which you can get out of a nice short summary for you to get out of the osteoporosis guidelines. And I think it'd be really helpful to print this out to, again, you could even print this and give it to some clients who've got more of an interest in some of what they will think of as maybe more technical work, to just say, this is what the latest evidence is telling us that you need to do. These are some of the things you need to do. So you can see that we're looking at trying to get our clients to be on this regime. Not only is this regime going to be good for their osteoporosis, it's going to be good for their falls prevention, because we know that exercise is going to be one of the key things for preventing falls in this population. And as I'll come on to talking about, the key thing is going to be how to get people with osteoporosis and arthritis to do exercise. When you meet people with arthritis, you may find they have not been exercising, and so they're going to need graduated exercise. They may need to add flexibility, so they may need to do a good flexibility component before they start their balance and strength work. And we know that for people with arthritis, low impact activities like water, cycling, Tai Chi, these do build aerobic capacity and have pain relieving effects and give the person confidence and help build their posture, and do have some strength elements, not as much as you would need to have to build impact, but they do have some. So very important to encourage your clients with arthritis to build these types of activities into their days and into their exercise programs, combining them with strength and balance work. It's important for arthritis to help people to time around the medications they take, to make sure they're taking their medication regularly, and to deal with flare-ups, and reminding them that they can come and go to their exercise if they have to, and not letting them stop. We know that one of the main reasons older people stop exercising is an injury. Now, it can be that the injury is preventing them, but often it's like you and me. People with arthritis, like anybody, if we might have an activity we do. Perhaps we are going to visit our friend once a week for a coffee. Our friend goes away. Somehow, when the friend comes back, we don't seem to get back to our coffee because we've lost that habit. That's the worry for people with arthritis, or if they have osteoporosis and a fracture, that the time when they could recommence has to be rescheduled into their activities. So that's a really important point for us to think about, and we'll talk about this motivation. Also, the evidence tells us that it is important to overtly talk with people with arthritis and osteoporosis about their beliefs and attitudes. And here's some recent work which I think is very good about. They did some examining via asking people to rate using Likert scales their attitudes and beliefs to exercise, people who had arthritis and they who had OA of the knee. And they found that 69% of people with knee pain had a stronger belief that exercise was dangerous than the average person without pain. And that is one of the issues for us. And we know that the latest guidelines for knee OA have specifically now asked health professionals, they've really tried to put this in the guidelines to say, please avoid saying that your pain is caused by bone-on-bone changes. And interestingly, I was at a dinner on Sunday with some people I hadn't met before. And of course, being a physio, people often bring up things. Someone brought up their knee pain and immediately said, my doctor told me that I have just bone on bone, so I can't expect to get any better. So we really do need to stop saying that. We need to tell people the evidence suggests that exercise and moving around can really help you, and building up a set way of doing exercise is going to help you. You will be able to improve. So really important point. And interestingly, a recent meta-analysis that looked at people with hip and knee OA found that it was really important that people do active exercise, and they particularly looked for people doing resistance exercise and other exercise. And they found that all interventions where people did about 6 months exercise, not always 6 months, and there was some better activity at 6 months, better results, but generally between 3 and 12 months, if people did exercise, resistance exercise, they had reduced pain and they had improved physical function. What was particularly interesting about this meta-analysis is they found that there was not a significant effect by volume or adherence. So people who did more intensive programs didn't have far better improvements in physical function. People who did less exercise or were less adherent to the program in the trial still had reductions in pain. And so it's really important to, I think this tells us that our patients, we need them to do some exercise rather than none. Don't worry if you feel they're not doing too much or you feel they could be doing more. Get them to start doing some resistance exercise because they will start to notice benefit. Some people are frail. It's easy to, even as therapists, buy into that belief with the older person who's frail and think that they shouldn't be doing exercise or they can't benefit. We know that one of the main treatments for frailty is physical activity and physical exercise. And mobility training in people with frailty helps people have clinically important benefits to their mobility. And people who are physically frail develop better energy and strength if they do exercise. And so if you have patients who are frail, yes, don't get them doing dramatic amounts of exercise that exhaust them, but give them a help to start doing small amounts of regular exercise and encourage them to feel confident that a little bit each day will help them feel better. I've had a lady who was doing no exercise and never did much exercise after her hip replacement. And recently, last year, somehow got into looking at some exercise programs online on one of the exercise shows, somewhere on one of the TV shopping type channels, and began to do some exercise each day watching this channel and kept on looking at the program. And she is over the moon at how much she's improved. She never realized. And so she developed some internal motivation, which was tremendous. So you see, this is a really important study, I think, where they looked at what this study is interesting because they thought to themselves, what they tried to say to people in the community, what would be the easiest and most effective intervention to delay or reverse frailty in primary care? What's the easiest thing to do? If you look at this graph, you can see that things that are easy to do are taking us out to the right of the diagram, and things that are effective to do and show good effect are rising us to the top of the diagram. And you can see the thing that's up on the right and in the top, the most easiest and most effective thing for people who are frail is for them to do some strength exercises and have nutritional supplements. So for people who are frail, these will normally often be people with arthritis or osteoporosis. That's what we need to be getting them to do. Now I'm going to start talking about barriers and motivators now, because one of the things you'll find is that people with arthritis, with osteoporosis, and without arthritis and osteoporosis will always be thinking to themselves, well, am I really at risk of falls? And often they're not really thinking they are. And you may find that they're thinking, well, can I do something to reduce my risk of falls? Can I improve my bone strength? Can I reduce my pain from my arthritis? So that's something that we've got to help people to manage. We've got to give people the evidence about falls such that they realise they're at risk. So we need to engage with older adults. That's what the World Falls Guidelines tell us. We need to understand what they are thinking about falls. We need to understand what they are thinking about their arthritis so we can gently begin to tell them. I find this is a very helpful comment to give to people with falls. When people say, oh, I don't know that I'm at risk, or I don't think about it, I just ignore it, I will often bring up the point to them now to say, you know, it's really interesting in Australia, road traffic injuries cost us $400 million a year, but falls cost us 4.7 billion. Falls are a really big problem and they're happening to all of us. And I think it's really important not to frighten people, but to alert them that falls are a problem. And so we need to get our older people, clients that we see, patients, to remove their idea that falls are an accident and remind them that, well, actually falls are due to various risk factors and we can address those. We want to give them confidence. We want to say there are lots of things you can do to prevent falls, and just remind them these are kind of some of the simple, safe tips you can do. These are easy things. We can all do these and they work well. We can remind them about wearing their sunglasses, wearing their glasses for a start, avoiding multifocus. We can say these are all really handy tips. And we can remind our people, particularly those with arthritis or osteoporosis, we can just give them some simple facts and say, one of the things I want to alert you to is that most falls, up to 50% of falls, happen when people are alone. And if you have arthritis, you might not be able to get up off the floor. So planning is going to be critical. Don't worry about a fall. If you have one, of course, we're wanting to prevent them, but if it happens, it's happened. But you need to have your plan. And so I often talk to older people now about prepare and practice and have a plan. Have a plan for what you would do about falls prevention, and really overtly discussing this with people with arthritis and osteoporosis is important. Now, you'll have heard, I think, Dr. Alyssa Burton talk about getting up off the floor, and that's something you want to bring into your older clients. And for those that can't get up off the floor, you want to talk to them about, have you thought about having a watch so you can make calls from your smartwatch? So, you know, those are things you want to be talking about. It's very important now, we're going to talk this last 5 minutes just about how do we take our patients with arthritis and osteoporosis and generally and address the barriers they have to engaging in falls prevention. We had an interesting study which we conducted a while back where we showed older people these falls prevention messages we've made on video, and we found that it did increase their knowledge. So that was very pleasing. People developed good knowledge and awareness, and they were very impressed with that, actually. They felt they knew a lot more, and they were surprised that they hadn't known that falls were such a problem, and they felt motivated. But one of the things we found was there was a divergent view on the way the message was delivered. Half of the people felt very positive and said, wow, you've really alerted to me, and I'm really pleased and I like the message. We tried to make, we had some messages that were, some messages were fun and some were more serious, and we found the views split 50-50s on each message. So some felt that the message was important and gave them a positive emotion, but others felt, oh, the messages are negative. Even if you're telling me that I'm getting older and I need to turn lights on, oh, that's making me feel old. So people have age-related ageism, can be internal in themselves. And 68% of all people over 50 agree ageism is a serious problem in Australia. So we need to think about our own internal ageism, and we need to really try to work hard to combat it wherever we go. Anytime any patient in hospital says to you, oh, well, I guess I'm just old, we want to say, oh, no, that's nothing to do with it. You're perfectly great for your age. We just need to be working to improve your strength. Age has got, no issue. You don't need to worry about that. We really need to deal with that. And we found this recently when we interviewed older consumers. We've published this work now, that a lot of our older consumers actually brought this up. They said, well, when I go to hospital, I felt I got put into the older person category. And some of them felt quite annoyed about that and said, oh, this is a comment from one of our participants who said, it was almost like you get to a certain age and you've got certain conditions and it's all over Red Rover. And that made me quite angry. So ageism is something we need to combat, because some of our older clients are thinking, well, I won't be good at doing exercise because I'm old, or I won't go to the gym because I'm older and I won't fit in. That is an alive and well perception that we need to address, because it stops people being motivated to go and join in exercise groups. People with osteoporosis can often have a fear of causing injury, so it's important to remind them that, no, you can do more. Encourage them to do more and remind them exercise will make you strong, it will make you steady, it will make you straight. I've developed this from the UK exercise on osteoporosis guides and consensus. So it's important to say, no, if you have bone osteoporosis, what we need to do is build your strength, because that's going to help your bone strength as well. Remember that people are going to need many motivators to try to help them, their peers, their family. They're going to need to feel they want to belong. They're going to need to observe others being active. They need to find a way they can exercise. These are things, as a health professional, you need to tailor your discussion for that person. So you can see this person on the left and the person on the right will need a very big, different discussion. But have a look at the smiles on their faces. Whoever has designed their program, it's made them feel, I'm confident, I'm achieving, I'm doing this program. We recently have been doing a trial in Perth, and very interestingly, we were recruiting people with chronic disease who all needed to exercise. That was a given. They had quite significant health problems. And we found that 55 of the 77 people we invited to exercise did not want to exercise. And they didn't want to do it because they said they were too tired. They felt their health problem precluded them, whereas, of course, their health problem meant they did need to do it. They had low motivation. We provided a program where we paid for them to go. It was in their local area, and they were given good assistance, and they could choose from different varieties, but they still had low motivation. So it comes back to providing those resources for your clients so they feel motivated to do the things that you need them to do. I'm just going to finish by saying you can use our Safe Exercise at Home National Physio website if you like. It is a free website for older people, and it's set up for older people as well as health professionals. You can download booklets for older people. You can feel free to direct them to the website. You can use it in any way you like to help older people to exercise. I'm just leaving that there for you as a resource. So remember, for your people with arthritis and osteoporosis, one thing that is going to be important is to get them to do the exercise that can help them. So you've got to build their self-efficacy for exercise. If you say to me, my clients won't exercise, I'm going to say to you, okay, what are you doing about it? So that's what we need to do. We need to think about how to do it. Positive view on aging is key. Saying every day, you are never too old, you can do it, I know you can do it. Recommending. We found that in our very research trial, our large trial at Swan Districts Hospital in the day. If a physio said, I think you should do this exercise, patients were significantly more likely to do it. Remember, don't be reticent to start small. Small works. The more inactive people are, the more if they start doing something, they will work. So be positive about solutions. Make sure that you conduct these falls risk checks, that you do osteoporosis risk checks. Give people good advice. Screen their balance so that you can give them important tips for their balance exercise. Remind them and link them up to high quality resources. Give them a tailored plan that they can do. Keep saying to them, you are never too old. This is a lovely slide I like showing. This competition is actually on this week, where we'll have older men, and everyone who's had a hip replacement is playing a game of hockey against those who've had a knee replacements. And the winner is a joint arthroplasty trophy. So you are never too old, regardless of your knee replacements, your arthritis, to be being really active. So thank you, everyone. And again, I'd like to thank my team and all the people who are helping us to be active, and open for questions and comments, of course, too.
Thank you, Anne-Marie. That was a great presentation, and I love the finish with the hips and the knees. Looks like it'll be a good game, good match on the weekend.
I think it will be.
I have had one question come through from Miriam, and she's referring back to the slide you had from Healthy Bones on the exercise chart, where it talked about the impact exercises, and it suggested doing at least 50 impacts per session. Would that equal like 50 jumps, or what would you be looking at there?
Yeah, my interpretation is that it would be looking at 50 jumps. However, you would be thinking, it depends what people are doing. So if someone is doing skipping every day, they probably can do 50 skips. If they've been doing it some weeks. If they haven't been doing any, they might start with literally 3. I've seen people at the gym, my own gym, start with doing 5 step-ups, 5 step up, 5 step down. And they might build up, and some, in 3 months, they might be doing 50 step-ups, 50 step downs. So you would certainly adapt, and remind people they can be doing standing foot stomping. They could do 10 stomps. They could start with 5, build to 10, build to 15.
So it's all about that exercise and knowing your client really well to start with.
Yes.
Miriam also adds, is impact important only for lower limb, or should you also be looking at things like boxing or catching a medicine ball for upper body?
I think upper limb is important for people with osteoporosis, partly to try to maintain posture. So I would try to do what I think can be nice for people with osteoporosis is, rather than do, now then I'm not the exercise specialist with upper limbs. I tend to feel we focus a bit on the lower limb, but I would suggest doing work that's going to build posture as well. So although boxing will be, if someone would like to do boxing, if it's a gentleman who says, they feel they enjoy boxing, great. But I like the idea of doing push-outs from the wall, or sort of the push-outs from a low bar, so that, or might be reverse push-outs from the wall, so that you get the strength in the shoulders alongside the posture. So I think you could do a bit of both.
Yeah, and posture is definitely important there.
Yeah.
Okay, I'm just might switch back to our slides. If there's no other questions.
And I'm not sure, someone might have a comment or two. Please feel free to put your comment in, something that you might have found works for you or comment you've had on a client.
Well, Miriam, thanks you for that explanation.
Yeah.
I just wanted to say that, great to see the connection between the resources that Stay on Your Feet provide and the recommendations you suggested, all those key messages about not just the exercise aspect of caring and looking out for our older adults, but also talking to them about the other things that they can do to reduce their risk for falls. So thank you for that, Anne-Marie.
Yes, what I've come to see, I think, is that Renata, I think that's a really good point, is that it's sometimes good to give people some small tips that they can immediately do. So something like saying you can turn on the light at night, that's a really handy thing to do. And then combine that with let's set you up with a routine of 10 minutes exercise a day. You've given them a few manageable bite-sized chunks that they can do. And I'm a great believer now in telling people to pass the message on to others of their friends so they can say, oh, that's what I've been told to do. And I'm finding it's working for me. So, yeah, I think it's important. I will send the slides round to everyone afterwards. Everyone, I'm just going to make a PDF of them so you'll have those links available.
That's fantastic, Anne-Marie. I might just switch to our slides now if I can, Anne-Marie.
Yes.
Fantastic. Oops, where are we? Yeah, unless there was any more questions from anyone. I did get thank you from Mandy. She's certainly going to look at changing her language, not talking about exercise as she finds that it puts people off, and just about keeping moving, which I think is important as well. So our resources, as Anne-Marie indicated in her presentation, are available free online. You can download them or you can actually order them and have them delivered to you free of charge. We have some upcoming training early February, which is looking at older adults and preventing harm from alcohol and other drugs pilot project. So it's basically for anyone who is working closely with older adults and would have the opportunity to apply the Assist Light screening tool. You can find out more about that on our website, and you just click the QR code. I'll also put the link in the follow-up email for you guys. Apart from that, our free e-learning opportunities are always available online and easy to access through our learning modules page. And please, we also ask people to keep this conversation going and subscribe to our Falls Prevention e-news. It's delivered straight to your inbox, and we put the latest training and resources and information in there. We also invite people to join our Community Falls network. It meets quarterly. We've just had ours a week ago, and the next one will be in February. So please reach out if you'd like to join that. It's a great opportunity to share learnings and solutions in the falls prevention and safety promotion. And lastly, we would appreciate your feedback today. We do better by learning through what is important to you. Suzanne has put the link in the chat box, and again, that'll also be included in the email. So please respond to our evaluation form. It'll only take you a minute or two out of your day. So thank you. And we hope you found today's webinar of interest. We look forward to connecting with you again sometime in the future. And thank you very much, everyone, for giving us your time today. And thank you, Anne-Marie Hill, for a wonderful presentation.